of this patient, as I mentioned earlier, usually there are multiple traumas, so they need resuscitation, they need pain control, and need splintage. Partial reduction may be indicated to prevent skin breakdown, as what we do with ankle fracture dislocation. Open injury, they should be documented, clean and dressed, and treated with antibiotic. Probably there are very few better examples than Pilon fracture of the aphorism that a fracture is a soft tissue injury with a broken bone in the middle. And historically the treatment started around 1960s, when there's a lot of open reduction and fixation using the AO principle. However, it was realized later that the soft tissue management was poor, and there was horrendous complication, and people get off the open reduction and fixation, and they moved into external fixator. And probably the beginning of the 20th century, people started to do a sort of marriage between external fixator temporarily with a staged RF or minimally invasive percutaneous osteosynthesis. The current practice now is temporary stabilization and delay in definitive surgery until the soft tissue have settled. Then joint reconstruction through a small incision directly over the main fracture line, and reattachment of the articular fragment into the metaphyseal fragment with minimal incision plate. So this is the patient arrived, taken to theater for spanning X-fix and reduction, and while the soft tissue settles after 12 days, open reduction and fixation. This picture was taken from the orthopedic hyperguide presentations. Timing of open reduction and fixation, again different people got it different time. Tordarson got it 5 to 14 days, Sanders got it 10 to 21 days, and Pauli and Ellis got it 14 to 21 days. The whole idea is that once you are satisfied with the soft tissue, probably is the time right. In very few cases in which there's minimal soft tissue damage, probably you could fix it primarily. But I believe this would apply for very few cases, at least in my experience. Neurosurgical management, INE 1988 reported his series when he treated all these into plaster of Paris for 12 weeks and non-weight pain for 10 weeks. There were no data to show whether such protective restriction is necessary, and he found that displacer community fracture did poorly in the cast. There are different forms of external fixator now we could use: bridging X-fix, circular frame, or hybrid. Now, after 2 to 5 years, 15 to 30% were disabled, 40% had changed job as a result of the fracture, and 50% has developed osteoarthritis. For them, 10% needed ankle fusion. Important thing here, Marsh found that patient continued to improve for up to 5 years. So really, unless you're pushed to do ankle fusion or ankle replacement, probably you need to consider this 5 years period in which the patient still can improve. Result of surgery, only one RCT has compared internal and external fixator by Warsh in 1996. Found no difference in clinical outcome, but a higher incidence of severe soft tissue complication in the orphic group. Result of surgery, Papadakis, 2008, did a systematic review of the literature on external fixator and found bridging and non-bridging fixator were similar. There was a higher risk of malunion in the bridging series, but this could be due to confounding factors such as initial fracture severity. Thank you very much. If there's any question, please fire away.